With that, it is now my pleasure to hand you over to Dr. Brian King.
Thanks so much, Dr. Ogden. So as you heard before, I am Dr. Brian King. I am the Deputy Director for Research Translation in CDC's Office on Smoking and Health in our Chronic Center. And I'm also concurrently serving as the Deputy Lead for the Strategic Science Unit in CDC's COVID-19 response. And it's really my pleasure to speak with you today about a silver lining, if you will, when it comes to the COVID-19 pandemic. And understandably, we've heard a lot of negative and various factors related to public health over the past many months as the pandemic has continued. But for every cloud, there is a silver lining. And I appreciate the opportunity to speak on one of those small silver linings today, particularly related to a non-communicable disease related risk factor, and that's secondhand smoke. So next slide, please. So when we talk about secondhand smoke, that's the smoke that comes from either the end of a cigarette or from the mouth of a smoker. There's actually two types. So I'm sure that over the years, many of you have been exposed in some capacity, whether it be a public environment or a private environment. But there are two different kinds. One is mainstream smoke, and that comes out of the mouth of the individual who's smoking after they exhale. And then there's also side stream smoke, which comes out of the end of the tobacco product. Which in this visual is a cigarette. In terms of the science, both of these types of secondhand smoke contain the same harmful ingredients. That's about 7,000 chemicals, as well as 250 which are toxic, and about 70 of which have been shown to cause cancer in humans. Next slide, please. So before I get into this context of COVID-19 and smoking, I wanted to give a brief background on the health effects of secondhand smoke, so that we're all starting from the beginning of the story so you can really understand how we got where we are and what the implications are for public health. So next slide, please. So we've been studying secondhand smoke for about 30 years now. Cigarette smoking has been declining in this country among adults since the mid-1960s and among youth since the late 1990s. And with, of course, the increase in cigarette smoking that occurred up until the 60s, we did see secondhand smoke exposure as well. If you have more people that are smoking, you're going to have more likelihood of being exposed in different environments, whether that be in a public place like a restaurant or a bar, but also in private settings. And that said, over time, the science has continued to build on the health effects of secondhand smoke. So of course, they're relatively a smaller list compared to the many adverse effects associated with smoking, which harms nearly every organ of the body. But when it comes to secondhand smoke, there has been a robust body of science for various outcomes among adults, including exposure being causally linked to stroke, lung cancer, coronary heart disease, as well as reproductive effects in women, such as low birth weight. But there's also effects among children, including middle ear disease, respiratory symptoms, lower respiratory illness, and also sudden infant death syndrome. And so I think it is also important to note that there is no safe level of secondhand smoke exposure. That was a major conclusion of the Surgeon General's report back in 2006. So we know that, of course, chronic long-term exposure is going to result in a lot of these adverse effects, but even brief exposure over only a few minutes has been shown to elicit a coronary effect that can be problematic long-term. Next slide, please. So where are we in terms of secondhand smoke exposure? So as I noted before, we started to see cigarette smoking coming down since the mid-1960s. And so there was a little bit of a delay when it came to secondhand smoke exposure. We didn't actually start seeing declines until the late 1980s. Well, why was that? That was because we started to implement public smoke-free policies, which prohibited the use of cigarettes or other combustible products in indoor environments like restaurants and work sites and bars. And so you could see as those policies started to proliferate at the local and state level, particularly in the 90s and 2000s, we started to see declines in secondhand smoke exposure. And so the first state to do this was Delaware in 2002, and then New York followed in 2003. But before that period, you had a lot of state localities in various states, particularly on the West Coast in California, all the way back to the early 90s that were implementing these types of policies. And so it's no surprise that as you started to see those policies implemented, you started to see those declines in secondhand smoke exposure. But we've still got 25% of the US population, and it's been stagnating over the past several years. The more recent data that aren't presented here show about 1/4 as well. So this is nearly 60 million Americans. So still profound exposure that's occurring, even though we have seen some progress in terms of implementing policies. Next slide, please. So what are the populations that are particularly prone to exposure? Well, there's 4 major populations that have higher levels of secondhand exposure. And this is from measuring cotinine in their blood, which is it's a byproduct of nicotine. So if you're exposed to nicotine, it becomes cotinine in your body after it's metabolized. And we see higher levels among children, non-Hispanic Black persons, and also persons living below poverty, and also renters, which is an interesting variable we've added in recent years. And this gets at the notion of multi-unit housing residency, that if you have someone living in close proximity to one another, you can do your due diligence and implement a smoke-free home policy, but that doesn't prevent you from being exposed from elsewhere in the building, including from adjacent units or hallways and elsewhere. And so we do know that people who live in closer proximity to one another, particularly renters or those in multi-unit housing, are also more likely to be exposed. Next slide, please. And so let's look at some trends here. This just shows where we've been in terms of non-smokers age 3 or higher exposed since the late 1980s to 2014. And you can see that we made great progress, but you also see this stratification by age. And so kids 3 to 11 are more likely to be exposed than even older teenagers, and also those over 20 years of age. And why is this, folks? Well, this is because youth have a less luxury and inclination to remove themselves from smoke-filled environments. And we know particularly for kids, the home environment can be a primary source of exposure. And so you still have higher levels among these populations that don't necessarily have that ability to remove themselves from a smoke-filled environment like an adult could or would if they were exposed. Next slide, please. But it's also important to look at health equity as well. And frequently, we always look at this overall exposure decline, and we lose sight of the fact that there are variations by population groups. And that particularly includes children 3 to 11 years, as well as broader variations by race, ethnicity. These are the 3 populations for which the secondhand smoke variables are stratified in the National Health and Nutrition Examination Survey. And you can see here that we have a more pronounced decline among Mexican Americans, which is a proxy for Hispanics, as well as white non-Hispanics. And then you see a bit of a flatlining among non-Hispanic Black populations within recent years. And so again, we can't leave people behind. And this is also a health equity issue because you have disparities in exposure, which is due to multiple factors, including variability in coverage and protection by smoke-free policies, but also in the use of various tobacco products, including cigarettes. So next slide, please. So one last thing on the background in secondhand smoke is in remembering where people are exposed. And so when it comes to kids, most likely areas of exposure are private environments like homes and vehicles. And when it comes to adults, the most common places where they're exposed are in public places and work sites. But one interesting piece of information is that we know from the available science that if you implement a public smoke-free policy, that also increases the likelihood people are going to implement these policies in home settings. And so the longitudinal data that have followed people over time shows that you really get a twofer when it comes to implementing these public smoke-free policies. You not only reduce secondhand smoke in public areas like work sites and restaurants and bars, but it also increases the likelihood you're going to see an uptick in these types of policies in private settings, which is really beneficial, particularly for children and those other populations that are more likely to be exposed in these places. So really the first line of defense is those public smoke-free policies, which can include a variety of venues, including casinos, which is the topic of discussion today. Next slide, please. So where are we in terms of smoke-free policies in this country? Well, this is a map. You can see that we have made commendable progress over the past 2 decades, a monumental public health achievement. Back in 2000, we had no states with a comprehensive smoke-free law, which CDC defines that as the trifecta of policies covering work sites, restaurants, and bars. If you have all 3 of those are comprehensive policies. And right now we have over 24 states, as you can see in the dark blue, that have that comprehensive comprehensive label, but we also have some that are 100% in 2 locations and some in 1 location. And interestingly, there's also several states that don't have a law that covers these areas or has ventilation or other restrictions that we know are not effective to help mitigate the risk of secondhand smoke exposure. And it's no coincidence that the areas, particularly in the South, that where you have no policies are also the states with some of the highest rates of smoking prevalence. And so really there's this correlation between higher risk factor when it comes to smoking and secondhand smoke and lower likelihood of coverage from those proven evidence-based interventions that we know work. Next slide, please. And what's the impact of these policies? So regardless of the environment, whether it's a work site, a restaurant, a bar, or even a casino, we know that one, they improve air quality. The studies have shown, environmental studies, that the minute you stop allowing smoking, it reduces exposure to ultrafine particulate as well as the harmful constituents in secondhand smoke. And so elimination of the risk factor is the most effective way to protect people. We also know it improves health. There's dozens and dozens of studies showing, particularly among hospitality workers, that after the implementation of these policies, you see improvement in coronary outcomes, as well as other longer-term chronic outcomes as well. They also received strong public support. Back in the 90s, when these policies were new, you saw about 50%, and it followed the same lines as, higher rates among never smokers. But now there's broad population level support, well over 75% of the population, and even more than half of cigarette smokers support these types of policies prohibiting smoking in indoor environments. And of course, we also know they reduce exposure, they reduce smoking rates as well, and it's not only through a smoking cessation, but they also prevent initiation because you denormalize the behavior. And if a generation of kids don't see these products being used in public, then they're less likely to start themselves. And we also know that there's high levels of compliance with these policies as well. So there's a variety of different benefits from initiation to cessation to reduced exposure that really help reinforce the public health importance of these policies. Again, irrespective of the environment, whether it be a private setting like an apartment complex or a restaurant, a work site, or a bar, or even a casino. So next slide, please. So now let's get into this tobacco use and COVID-19 transaction. Next slide, please. So early on in the pandemic, there was a lot of discussion around what is the association between infection with SARS-CoV-2 and even severe illness as it relates to smoking, because some of the original studies that had a small sample size were showing even a protective effect of smoking, and folks were trying to understand what that potential impact could be. But as the science has grown over time, we have seen that there is increased severity of illness among people who are current or former smokers. And part of the underlying mechanism behind that is that we do know that nicotine serves an important role in terms of the receptor that the virus that causes COVID-19 binds to. So you see on the right here, we've got the human cell, which is in pink, and then there's these ACE2 receptors, which are those little gold claws. And so basically, those little gold claws are where the virus that causes COVID-19 docks on the human cell. Interestingly, ACE2 is also activated by nicotine exposure, and particularly among cigarette smokers. They have higher ACE2 gene expression and greater ACE2 receptor concentrations in their lungs compared to non-smokers. So you basically have a perfect storm here, where the place where the virus that causes COVID-19 binds is also a place that is highly activated by exposure to cigarette smoking. And so you would expect that effect, that if you are a current or former cigarette smoker, that there would be that more higher increased risk of severe illness. That said, next slide, please. CDC has synthesized the available evidence. In addition to older adults, we have added smoking to adults with the following medical conditions that have a higher risk of severe illness from COVID-19. Importantly, though, we have to make this distinction between incident infection and severe illness. And so this is severe illness. If you already have COVID-19, there is an increased likelihood that you will have a severe illness if you are a current or a former cigarette smoker. We do not have sufficient data to make any conclusions around incident infection. That is, if you're not currently infected with the virus that causes COVID-19, whether you have a variable risk if you're a current or former smoker. And so more science is needed. But we do know that there's this link between smoking and COVID-19 severity of illness risk. Next slide, please. So that brings us into secondhand smoke. So where are we on the science there? Well, we're simply too soon in the pandemic to have some robust science for us to assess what this relationship is with secondhand smoke. Yes, secondhand smoke contains several of the same harmful constituents as the smoke that's inhaled by a smoker, but not at the same levels. But what we do know is that secondhand smoke is associated with immunosuppression, which is similar to smoking and could be another underlying driver that's contributing to this increased risk among people who smoke. And so the available science does show that chronic secondhand smoke exposure worsens pulmonary inflammation and compromises ability to combat chronic and acute respiratory infections. And so this could put someone at risk if they did have these underlying conditions and they're exposed to secondhand smoke at higher risk of severe illness, but we don't have sufficient science to make any conclusions in that regard. Next slide, please. But what can we say? Well, sans the ability to make a definitive conclusion between exposure to secondhand smoke and risk of either SARS-CoV-2 infection or severity of COVID-19, what we do know is that COVID-19 is a respiratory disease. It's primarily spread through respiratory droplets. And we do know that transmission risk is going to increase when people engage in behaviors that increase the likelihood of transferring respiratory droplets. And so that transmission risk will also increase when people engage in activities that increase the likelihood of touching their faces or mouths. And so that falls within the standards of cigarette smoking, as well as using an e-cigarette. Whereas if you're engaging in a behavior that could increase the transmission of respiratory droplets, this could have an effect on the risk of transmission of the virus that causes COVID-19. And so, that said, we don't have, science to say that secondhand smoke is a vehicle for transmitting, but we do know that the underlying behaviors associated with smoking and secondhand smoke exposure could increase the risk of potentially being exposed if a person was positive for SARS-CoV-2 and did engage in smoking behaviors in the near vicinity of someone who is not. Next slide, please. So that brings us to this issue of secondhand smoke in casinos during COVID-19. And so now we've got the background of where we are in terms of secondhand smoke and smoke-free policies, and also COVID-19 and secondhand smoke. But what was this phenomenon that occurred within the past several months when it comes to casinos? So next slide, please. So there's been a lot of attention in the media around various entities going smoke-free, and many of them have been concerned about the potential for this risk around increased transmission. Obviously, if you're smoking, you are not wearing a mask, and so it could increase the potential for transferring respiratory droplets. And so many casinos have identified this potential risk, and as a result of COVID-19 have implemented smoke-free policies. And it's in many interesting areas. One of the most notable was Park MGM in Las Vegas, which it was actually the first casino in the Las Vegas to go smoke-free. There's certainly smoke-free casinos elsewhere in the country, but as a result of COVID-19, the first casino on the Strip implemented this type of policy. So it's very noteworthy that we're seeing a foot in the door, if you will, in terms of the implementation of these policies. And this is important because when it comes to smoke-free policies, we've always seen them galvanized from the bottom up, where you have these localized implementation. You start to see people say, well, these actually aren't that bad, and they're helping protect health. There's not this adverse health effects when it comes, to impact on business, and this is a good thing. And so as you engage key decision makers at that local level, we've seen this broad adoption at the broader level, and that's what we're starting to see when it comes to casinos as well, where you see these isolated pods of these casinos going smoke-free as a result of COVID, and that's a good thing for public health, and we'd hope they continue, but there's further evidence and data to help support this wave. But it's very important to acknowledge that this is a relatively new phenomenon that's occurring, and in areas that we haven't previously seen this level of public health momentum. Next slide, please. So what are the benefits of smoke-free policies casinos? Well, they're above and beyond what we see for areas like, private settings like multi-unit housing, or also in work sites, restaurants, and bars. Cost savings on going smoke-free, including spending less money on air filters, zero time removing tar, cleaning residue from machines and cigarette ashtrays, fewer employee 6 days from secondhand smoke illnesses, including dealers, as well as people who are working on the floor in these casinos, and also a drop in health insurance costs costs from fewer employee doctor visits. So it's not just the health argument here, particularly in the context of casinos. You also have that economic benefit, which we know from public health lovers for many years, that different stakeholders listen to different messages. And so on top of the very important public health argument, you also see a cost savings here that can impact the bottom line. And so these policies could ultimately be good for business in many regards, on top of being good for public health. Next slide, please. And they're also highly supported by the public. And so CDC released a study a few years back now that assessed public attitudes, not only among all adults, but also adults who patronize casinos. And it was about 75%. So again, we're seeing similar levels as we do for the public around these policies being supported by not only the general public of potential patrons, but also the people who are actually going to these venues. And this is an important lever because a lot of casinos believe that it's going to hurt their bottom line and they're going to see shifts in business. But you do see this continued support for these types of policies, which again have been implemented in some places, which I'll show you shortly, but have started to percolate again as a result of COVID-19. Next slide, please. So here you can see the statewide laws requiring smoke-free gambling venues in the United States. And this is as of January 1st, 2021. So it's about 2 months old, but not too shabby in terms of timeline. And you can see that the places that have these policies, many of them have folded them into their comprehensive smoke-free laws already. And so you see a lot of these same states in light blue were the same ones that had those comprehensive policies earlier on in the map I showed you in this presentation. But you've also seen a lot of statewide momentum when it comes to COVID-19 reopening guidelines, including Michigan and also Pennsylvania, and importantly, New Jersey. And so why is New Jersey important? Well, outside of Las Vegas, it's a major gambling hub in terms of Atlantic City. And so seeing that level of implementation of a broad public health policy in this environment, particularly at the state level and a major hub for gambling and casinos, is very important. It's definitely a public health win and shows an added benefit in terms of protecting not only the workers, but patrons of these policies. So you can see that there's already this foundation of smoke-free policies in casinos, but we've seen a considerable momentum when it comes particularly to COVID-19. Next slide, please. So this is specifically little pins that show you the places that have implemented these policies since COVID-19. So it's not just the state level, it's actually the local level as well. And so each pin documents a casino that has gone smoke-free. And it's not just commercial, but also tribal casinos as well. And so there's definitely momentum across the spectrum in terms of implementing these policies. As I noted before, New Jersey is a really important one, including Atlantic City casinos that have gone smoke-free. And also many of these casinos on the maps are tribal casinos. And while we had some tribal casinos that were already smoke-free, this shows considerable progress, particularly in the West, looking at Arizona and California, Oklahoma, Oregon, and also Washington, and also in the Great Lakes area in Minnesota, Wisconsin, and Michigan. And so this progress has been important. And as I noted, you also see the blips over in Las Vegas area. The first casino on the Las Vegas Strip to ever go smoke-free was the Park MGM. Now, the big question here is, will these casinos remain smoke-free after COVID-19? And that's a very important question. We, of course, know the immeasurable amount of science showing that these policies are effective for protecting health and that they don't have an adverse effect on business. But now we have our foot in the door in terms of implementing these policies. And I think it's important to continue to remind ourselves of the importance of those benefits as this moves forward. And so if all these casinos were to continue smoke-free, even post-COVID-19, this could have an immeasurable benefit in terms of not only protecting the public who attend these venues, but also workers who are working 8-hour or more shifts per day in these environments. So next slide, please. So here's the key takeaways from my presentation today. So if I put you to sleep, you can arise from your slumber. Bottom line here is there's no risk-free level of secondhand smoke. We know that it contains 7,000 chemicals, 70 of which have been shown to cause cancer in humans. And it's not just chronic exposures. It's also brief exposure. Secondhand smoke exposure does not follow a linear effect when it comes to coronary outcomes. When it comes to lung cancer, it does. So the longer and more the exposure, the higher risk. When it comes to coronary outcomes, it actually peaks very quickly and then plateaus off. And so what this tells us is that even brief levels of exposure can be problematic for health, including those that you would experience if you patronized a business such as a casino for a short time period. When it comes to this transaction between smoking and secondhand smoke and COVID-19, we know the transmission risk of SARS-CoV-2 increases when people engage in behaviors that increase the likelihood of transferring respiratory droplets. And so that includes the act of smoking, where you will presumably, not wearing a mask when you're engaging in that behavior, and also, potentially exposing other people to secondhand smoke. That said, we do know that smoke-free policies, and particularly the ones that have been implemented recently, are going to reduce that secondhand smoke exposure and that risk. They're going to promote smoking cessation, prevent smoking initiation among non-users, particularly younger people, and also denormalize smoking as a broader environmental implication. And so when it comes to the long-term effects here, the COVID-19 pandemic has resulted in an increase in smoke-free casino adoption, which is certainly a silver lining of what's happening in the context of the pandemic, which would be beneficial if it continued. But it's to be seen what that impact was. But as I noted before, the history of tobacco control over many decades is that when you implement these policies at the local level and people, particularly key stakeholders, see the benefits and they realize that it doesn't significantly rock the boat in terms of a detriment to patronage or income, it can be a very important strategy to protect public health, and has been done in a variety of cities and states across the country that have continued to engage in business. Next slide, please. So with that, I'll end with my contact information. I have a famous email, baking@cdc.gov. So you can send me questions on tobacco or your questions about various recipes, salmonella and cookie dough, you name it. I've probably received it to that account. But if you have further questions beyond those that we may not be able to answer today, feel free to send them to that email, and I'm happy to triage them to folks in CDC's Office on Smoking and Health. We have a variety of resources at CDC on this issue in terms of how to quit smoking, and that's really important. We've got 34 million American adults who continue to smoke, and also a diverse array of products that people are using in this country, including kids. And so one of the best things you can do to protect your health is to quit smoking, particularly among adults, given the association between smoking and COVID-19 disease severity risk. We also have a lot of resources on smoke-free policies, irrespective of the environment, the benefits of these policies, and a lot of resources and infographics, including several that have been developed in the context of casinos in coordination with our colleagues at the Americans for Non-Smokers' Rights Foundation. And finally, COVID-19 resources on the far right, cdc.gov/COVID-19, including the latest available science on risk factors for more severe illness, which again currently include current and former smokers. And so with that, I encourage you to look at those resources and also our social media. The CDC has a tobacco-free handle with a variety of different resources, and we are on every major social media outlet, including Pinterest. So if that does not get you excited, I'm not sure what will. So with that, I believe we're going to turn it over for question and answer, and thank you for your time today.
Thank you so much, Dr. King and Dr. Ogden, for those fantastic presentations. Before we move on to the Q&A portion of the call, please take a moment to answer the questions through the poll on your screen. For those of you who submitted questions in advance of this call, thank you so much. We've received many excellent questions, and we'll try to get to as many as we can today. Okay, so I've bucketed these by presenter, and Dr. Ogden, if you could start us off by answering this first question. Does CDC have any estimate as to when COVID vaccines might be available for young people, including those under the age of 18 or 16?
Well, thanks. I'm happy to take the first question. So at this time, children and adolescents younger than 16 years of age are not authorized to receive the Pfizer-BioNTech COVID vaccine. And children and adolescents younger than 18 are not authorized to receive the Moderna COVID-19. There are no vaccines against COVID-19 currently authorized for children younger than 16 years, but multiple vaccine manufacturers have pediatric clinical trials underway.
Thank you so much. Stay tuned for more information. The second question is also for Dr. Ogden. Knowing that the protection from COVID-19 is not automatic after receiving the last dose in your immunization series, when do you consider the vaccination to be effective?
Well, it takes time for your body to build protection after any vaccination. And COVID-19 vaccines that require 2 shots may not protect you until a week or 2 after your second shot. It's important for everyone to continue using all the tools available to help stop this pandemic as we learn more about how COVID-19 vaccines work in real-world conditions. Cover your mouth and nose with a mask when you're around others. Stay at least 6 feet away from others. Avoid crowds, avoid poorly ventilated spaces, and wash your hands often.
Good advice for all of us. Thank you. Dr. Ogden, another question about a specific population. When are individuals with developmental disabilities going to be vaccinated?
That's a good question. It's important that people with disabilities get the COVID-19 vaccine when they're able. People with disabilities can be a part of any of the vaccination priority phases as outlined by the CDC vaccine rollout recommendations. Some states include people with disabilities in phase 1A or phase 1B. You can talk to your state health department for the most updated information on when vaccine is available and when you can get vaccinated. Disability alone does not put you at higher risk for getting COVID-19. You may be at higher risk because of where you live, such as a long-term care home. You may be at risk because you need to have close contact with care providers. You may also be at risk because you have difficulty wearing a mask or staying at least 6 feet away from other people or washing your hands. Many people with disabilities have diabetes, cancer, heart disease, or obesity, and these conditions may put you at higher risk of severe illness due to COVID-19. In addition, one specific cause of developmental disability, Down syndrome, in and of itself may put one at higher risk of severe illness. Talk to your doctor about whether your health conditions or health conditions of persons for whom you serve as a caretaker may put you or them at higher risk for getting very sick from COVID-19, and about getting a COVID-19 vaccine.
Thank you. Another question comes from a company, and they're asking, we are interested in knowing more about on-site vaccine clinics for our company.
CDC has provided guidance for planning vaccination clinics held at satellite, temporary, or off-site locations to assist with jurisdictional planning and implementation of these clinics by public and private vaccination organizations. Other users of the guidance may include public health preparedness professionals. The guidance primarily focuses on clinical considerations for planning a vaccination clinic, including vaccine storage, handling, administration, and documentation.
Great, thank you. Dr. Ogden, can you share what CDC's position is about aerosols and the consequences for the protection of workers?
Sure. The COVID-19 pandemic has raised many questions about the transmission of the virus that causes COVID-19, SARS-CoV-2, including the possibility of aerosol transmission. In the workplace, workers may encounter asymptomatic, pre-symptomatic, and symptomatic individuals who are infected with SARS-CoV-2 and may expel airborne particles containing the virus. Aerosol scientists bring a really unique understanding of airborne particle behavior to infectious disease transmission studies. In fact, a recent commentary in Aerosol Science and Technology, COVID-19 in the Workplace, Research Questions for the Aerosol Science Community, presents some of the questions surrounding droplets and aerosols containing SARS-CoV-2 and provides suggestions for future research topics. And this commentary can be accessed at the link shown in the chat. In addition, there's a link in the chat to an OSHA publication for preparing workplaces for COVID-19 that sheds further light on consequences and protections for workers.
Thank you so much. Dr. Ogden, that's not the last we'll hear from you. I'll ask you if you have any parting words, but first, I'm going to turn to Dr. King to ask him a set of questions. First one is, are smoking rates increasing during the COVID-19 pandemic?
Yeah, so good question. The answer to that really can be based on a variety of different data sources. But one of the easiest to look at for more acute impacts based on COVID-19 is retail sales data. Because we ask a lot of self-reported surveys, but frequently they're only one time per year. And so getting that acute impact of COVID-19 is more difficult. That said, when we look at the retail sales data, and they're collected by the same companies, when you're watching a football game and they say X million people have watched a given show, well, those same companies also monitor retail sales in businesses. So if you go to a business and buy a pack of cigarettes and it's scanned, it records in a database. And so we can analyze those data, which CDC has done. And basically what we found on the cigarette sales is there was a marked uptick in sales around March of 2020. And that was largely stockpiling behaviors of individuals knowing that they were likely going to be not able to access business venues as well as other places as public health restrictions began to be implemented. And so after that initial peak, we started to see a decline over time as individuals utilized that stockpile. We also saw many people buying cigarettes in bulk, such as cartons, as opposed to individual packs, which also increased those sales. That said, steadily the sales continued to decline through 2020. And by the earlier first few months of 2021, we're about where we were in the beginning stages of 2020. And this is largely consistent with some of the self-reported data that we have from the first few quarters of 2020, which suggests that we're seeing some decline in cigarette smoking, and that initial peak with sales was largely stockpiling behaviors. That said, we're looking at about no change compared to last year, which is not a public health win. And so we still need to put the pedal to the metal in terms of reducing cigarette smoking. But what the good news is that at least based on the sales data as well as preliminary self-reported data, that cigarette smoking rates have not gone up, which was the concern that people may have increased anxiety or other drivers or relapse back to smoking because of the existing stressors associated with dealing with the pandemic, whether it be through work-related or also things happening at home with childcare. But at present, the good news is it's not going up, but it's also does not appear to be going down. So we've got to redouble our efforts to continue those proven interventions we know work to effectively help people quit, including increasing price, smoke-free policies, mass media campaigns, and getting resources to help them quit, particularly through quit lines, which can function irrespective of whether a person has to leave their home.
Thank you. That's a very helpful public health lens, and I'd like to turn to the personal lens now and ask maybe a different aspect of the same question, which is, what is CDC's message to people, those who have started smoking again as a result of stress from the pandemic?
Yeah, so we do know that although the population level data suggests that there's not a high level of people that are relapsing back, we do know that it is happening to some extent. And that's understandable given the past year has been challenging. But the important message here is that smoking won't help relieve stress. Frequently, people believe that going back to smoking is going to alleviate these stressors, but the available science indicates that could even make things more stressful in terms of the exposure to nicotine and related risk factors. And so the bottom line here from a public health standpoint is now more than ever, it's important to quit smoking to protect your health. Current and former smokers, as I noted before, are at increased risk of more severe illness from COVID-19 compared to never smokers. And it's important that you quit as soon as possible to not only diminish that risk, but also to diminish the notable risks associated with cigarette smoking in general, which can compromise the immune system and be problematic on multiple fronts in terms of health and well-being. The good news, though, is there are free resources available to help you. And as I noted before, one of the most notable is Quit Lines. 1-800-QUIT-NOW is a national portal that if you call that will direct you to your respective state quit line. And they can offer free behavioral counseling, which we know is effective to help people quit. And in some cases can also offer free nicotine replacement therapy to callers like the nicotine patch. Again, you do not need to leave your home for these resources, and they can be sent to you in addition to the telephone help. And also, if you're more inclined to go on the internet, cdc.gov/quit has a variety of resources to help people quit, particularly in these challenging times.
Thank you so much. I've got a lot of questions about quitting smoking, but I'm going to turn to vaping and ask, does vaping increase your risk of contracting COVID-19?
Yeah, so the jury's still out on this, but currently the evidence is insufficient to infer an association between e-cigarette use and either infection with the virus that causes COVID-19 or more severe illness from COVID-19. There was one study that got a lot of media attention a few months back, but it's important to note that that was a cross-sectional study, and so it doesn't show us what came first, the chicken or the egg, and it's possible that some of these youth that were more likely to get infected were also engaging in other risky behaviors that could put them at higher risk for contracting COVID-19. That said, we still need more research on this front, particularly on the young adult end, given that 1 in 5 of America's youth are currently using e-cigarettes. But right now, the evidence is insufficient to identify a causal link between e-cigarette use and either infection with SARS-CoV-2 or disease severity. But the same public health messages apply. If you aren't currently using these products, don't start. And if you are using them and you're a young adult or a youth, quit immediately. And if you are an adult smoker who may be using them for cessation purposes, even though they are not FDA approved or proven for that purpose, you have to quit completely and transition fully from cigarettes to e-cigarettes in order to maintain a benefit. Using both products does not provide a meaningful health benefit.
All right, thank you. This next question you spoke a little bit about in your presentation, but I'm going to ask anyway because it's an important point to make. And that is, wouldn't smoke-free policies hurt revenue for businesses, including casinos?
Yeah, so this is a question that's been arising for decades since we started implementing these policies back in the 90s in California. And the bottom line here is evidence from peer-reviewed studies examining a variety of objective measures, including taxable sales revenue and employment levels, show that smoke-free policies and regulations do not have an adverse impact on the hospitality industry. And in some cases, they can actually have a positive impact. And so, although there's been a lot of attention towards this potential for risk, the available science suggests that it is not founded in the scientific evidence through a comprehensive reviews that have been conducted at the international, national, state, and local level over many decades.
Great. Okay, one more for you, Dr. King, and that is, could you please discuss mask wearing and distancing as related to people who smoke?
Yeah, so, it ultimately just goes down to adhering to the public health prevention recommendations that we've already heard. And Dr. Ogden nicely articulated those earlier. There's several important ways to slow the spread of COVID-19, including properly and consistently wearing a mask, staying at least 6 feet from others who don't live with you, and avoiding crowds. In the end, the more people you're in contact with, the more likely you are to be exposed to COVID-19. And so using these and other proven interventions reduce the risk of being exposed. And that's going to hold irrespective of whether you're a current, a former, or a never cigarette smoker. And so the bottom line here from a public health standpoint, if you do smoke, one of the best things you can do to improve your health is to quit. And that's including during the COVID-19 pandemic. And if you do continue to smoke, it's important that you continue to adhere to those proven ways to avoid the spread of COVID-19, including wearing a mask in public when you're not actively smoking. And when you are actively smoking, use proven prevention strategies, including staying at least 6 feet from others and avoiding crowds so you're not inadvertently exposing them if you are positive for SARS-CoV-2.
Thank you so much. All right, this concludes today's discussion. Dr. King, Dr. Ogden, do you have any closing remarks or additional thoughts to share? All right, hearing none. Thank you everyone for joining today's call. A recording will be posted online on CDC's COVID-19 webpage and on YouTube in a few days. The subscription link to receive future updates and invitations is listed on the slide. Just enter your email and then search for the COVID-19 Coronavirus Partners subscription. Our next call will take place on Monday, March 8th. Our topic will be expanding the COVID-19 vaccination toolbox, an update on the Janssen EUA and new federal vaccination programs. Until next time, stay safe and be well.